Welcome to the Cincinnati Children's Hospital Heritage Video Series. These videos are a project of the Medical Staff Historical Committee. I'm Dr. Elaine Billmeyer, a pediatrician and a member of the Historical Committee. With me is Bea Katz, who is a longtime former employee of marketing and communications here at Children's. She's the author of a photo history of Cincinnati Children's that was published on the event of its 125th anniversary. So our topic today is the history of pediatric anesthesiology at Children's. And with us we have three members of the anesthesiology department. We have Dr. Ted Stryker, who is the former anesthesiologist in chief and also the former director of Outpatient Mason. We have Dr. John McAuliffe, who is the current anesthesiologist in chief. And we have Dr. Paul Samuels, who is also a member of the department. So thank you all for coming. Welcome. We like to start these off by asking each of you to kind of give us a little thumbnail biography. How did you happen to come to Children's? Your own little story. Ted, why don't you start, being the pioneer?
My story is pretty straightforward. I trained at Philadelphia Children's, and from Philadelphia went to Bethesda, Maryland, where I worked for the NIH. And it was while I was at the NIH that I went back to my training source and consulted with my chief and said, where should I go to practice anesthesia? And he said, well, how about where you came from? And I said, well, they have no one there. And the fact was that there was an adult anesthetist who came by every once in a while, and it was every once in a while, Robinson Kirkpatrick. And Robbie practiced every once in a while, and mostly practiced adult anesthesia. And he was only too glad not to come back to Children's. He was never comfortable doing kids. And I started here, having finished up at the NIH in 1968. At the time I started, there were 5 nurse anesthetists and no physician anesthetists. And the surgeons did all the prescribing for both pre-anesthetic drugs and pain medicine. And the nurse anesthetists were lovely ladies. They were all getting on in years. And I was able to begin a department, and I first came upon Dr. Ed Lowe in 1970, who was at the time at the University of Michigan, and he was anxious to leave there, and he came down here, liked what he saw, and joined us. And it was in 1973 that Dr. Jean Harrington joined us, and she stayed with us for, 17 years. And
I don't mean to interrupt you. I want to come back to the history of the department.
oh, okay.
But I would just want to let the other two
Please,
introduce
go
themselves,
ahead.
and then we'll come back to that. Yeah, because you're getting into the good stuff. Yeah. Go ahead, John.
Yeah, I did my anesthesia training in Brigham and Women's and then Boston Children's, and was one of the attendings at Brigham and Women's had actually at one point interviewed out, and something happened within the family that he was not able to move out, and said, you know, you ought to really go look at Cincinnati. And it was like, where is it? Long story short, my wife and I came out here one August and looked, and looked really good, and so made a decision to come out here, and did first for a week in May of '85, did an entire week of cases with Warren Bailey, and still came back, and it was actually a really good experience, but it was a lot of work, and came back in July to start full time. So it was July of '85, and been here since.
All right. How about you, Paul?
For me, I was a pediatric resident at Northwestern, and was considering other professional avenues within pediatrics, including pediatric surgery, et cetera, and was spending a lot of time in the operating room and fell under the wing of the head of pediatric anesthesia at Northwestern, a guy named Steve Hall, who went on to become a very important person to me. It really changed my destiny. And I ended up doing my anesthesia residency after I completed pediatrics and my fellowship. And at the end of training, when it came time to look for work, I approached Steve and I said, "What do you think?" And he, to my knowledge, Ted, and you can confirm this, I think he called up Ted and said, "You should hire Paul," and he did, and here I am.
Okay, great, great. So let's go back to, you were starting to tell us now. So you were the first pediatric anesthesiologist.
Here.
Here.
Yes.
Here. Not ever, I know.
Well,
No.
there weren't a lot.
But there weren't a lot.
No.
There weren't a lot, right, yeah.
There were just a couple of centers of pediatric anesthesia. Boston Children's had
Yeah.
pediatric anesthesia person, probably the most well-known one, by the name of Robert Smith. And he's the author of the main textbook of pediatric anesthesia. Philadelphia had a large and active department. Chicago was not known for its pediatric anesthesia. And Los Angeles was known, but was not in the same league as the ones farther east. The department grew. We hired, I think, 5 more people.
So you
And
had
as
you
Paul,
and Edlow and
Gene Harrington,
Yeah.
John, Paul, who else was here when you got here?
Ike Lee.
Ike Lee, yes.
Oh, I
He
agree,
was
sure.
a very early
Susan
member.
Yeah.
Eric Whitkugel,
Oh, she was
Ellen
later.
Adler.
Okay. What one I got here? Yeah, so we had Patty Gibbons.
Yes.
Oh,
Helena.
Patty, sure, yeah.
Terry.
And
So-
you kept the nurse to Neth.
Oh,
Yes, we
Jay.
did.
Yeah.
Just out of curiosity, how many anesthesiologists are there now?
Total, right now we have 59. Yeah, I
Golly.
mean, I'd actually count some of the pediatricians on the palliative care service, so,
Okay,
yeah.
yeah, we'll want to talk about that, yeah.
When Ted hired me, he said, "Paul, you're the last anesthesiologist we're ever going to hire."
That was not the truth.
That turned out to not be correct, and I should tell you, it also sort of filled me with great unhappiness, thinking that I was always going to be the junior person.
Interesting.
So
Yes.
one question that I wanted to ask is, how did you come to be head of the department? Were you hired in that role, or
I fell into
you
it,
fell into it?
yes. I'm sure that I was not hired in that role because there was no role. They'd never had anybody that do this. And it was by default. And I just happened to be there at the right time.
I see, interesting.
They didn't search the country for me.
They said he's here. It'd be
But it
good.
was a lucky find anyway.
Yeah, yeah.
So another area that we wanted to talk about, and sort of what you've just said suggests why it's an important question to us, is tell us a little bit about the history of the development of pediatric anesthesiology as a field, and
As opposed to adults.
yeah, and what are the challenges, what's different about giving anesthesia to a child as compared to giving it to an adult?
Aren't they just little
You want me to
humans?
talk about that?
Any,
All of
any
you.
of all, yes, yeah.
Well, pediatric anesthesia is obviously a division of the field of anesthesiology. It became a major division in about 1975 to 85. People didn't devote their practice or their field to pediatrics because it never was separated. Children are different from adults, and those who chose to practice full-time in pediatrics found out more and more about the differences, and such things as weight, temperature, oxygen tension, etc., began to rise to their deserved importance. And some of the flexibility that adults allowed anesthetists was not present in kids. And they required attention to major shifts in their physiology much more suddenly and much more frequently than did adults. And that was one of the attractions to me. That you had something that you didn't just outlast.
Yeah. You had to constantly respond to a challenge.
Yes,
here.
I mean,
Yeah.
it was always interesting.
Yeah.
Well, I think one of the other
collaborate.
challenges, Ted, for you was, not only was there sort of were there special challenges associated with caring for children, but the rest of medicine was also changing dramatically at that time, where new techniques such as cardiac procedures on babies who had previously did not have any kind of surgical options available to them were becoming available. And then in addition to that, the technologies that were out there that were fairly well developed in some arenas, like in the area of medical equipment, ventilators, things like that, were really unavailable for children, particularly young children, for a long time. And so, Ted was around when much of that new technology came out that was truly being used for the first time.
And I think, the other thing too, for me, I was very interested, of course, in cardiac, and so you look at the nature of adult cardiac, it's largely, coronary artery bypass, valve replacements, whereas with the children, it was a whole different, you were basically rerouting their physiology. So it was an entirely different way of looking at your patient. It's really about, okay, what sort of, Ted's thing, what are the physiologic changes that are happening, and how do I compensate for these as I'm taking care of this child, right? So that was one, and to Paul's point is not only cardiac, but other surgical specialties began coming with new procedures and new ways of approaching diseases, cancer surgery, lung surgery, other transplantation, other sorts of things. Then the field had to move to make these things available to children, right? So we had to think in terms of how can we take what we've learned from the adult side, maybe modify and apply this to children so they are able to benefit from the same advances.
Or create it brand new.
Right.
Yeah, very interesting. Another change that I'm aware of that's happened over the years is the move from inpatient surgery to outpatient surgery. Do you want to comment on?
That was something in which we were not pioneers, but we were the early people
Okay.
who did it.
Okay.
Outpatient surgery in the 1970s was a rarity. It was mostly limited to local anesthesia, and it was begun at the Children's Hospital of Utah, Salt Lake City, and they had the first large outpatient surgery area. And we adopted it in a major way in 1986, I believe. And it worked, and it was obviously the right thing to do, because you had kids who had the ability to recuperate so quickly that they didn't have to occupy a hospital bed, they didn't have to pay for hospitalization, and they didn't have to be separated from their parents. And so we started having them go home at the same day, and it worked very well. And now the great majority of our kids is outpatients.
Was cost the main driver back then, or was it more complicated that you talked
It was-
about?
it
I mean,
was-
they could go home with their parents
Yes,
instead of,
I think cost was a major one, but I think it was the idea that kids would certainly not suffer hospital infections,
Yeah.
not suffer separation from parents, cost certainly, and it was a less complex procedure overall. If you go somewhere and you plan to be there for 3 or 4 hours, it's a lot different and a lot easier from having to have a parent there overnight,
Sure,
et cetera.
Sure.
Though there was one innovation sort of surrounding this that I think this institution and Dr. Stryker did play a very big role in, and that was the area of parental presence during induction.
Okay.
I'm not sure if we're getting
Yeah,
ahead of
no,
ourselves
no,
here,
no,
but
no. Let's talk about that.
Yeah.
Let's talk about that. Yeah.
And maybe we can do it in the context of Outpatient Mason as a facility, because that was our first satellite facility, and I know you had a very instrumental role in establishing it.
Yeah.
The induction rooms were part of the design.
Yeah. So how did that come about?
Yeah.
Well,
What was your role with
Right.
planning that satellite?
I had several conversations with Dr. Schubert about what we were going to do about our patient load, what we were going to do about the new idea that more patients were going to go home the same day. And he said, well, we've just bought a piece of property in Mason. And I said, where? And he said, in Mason. And I said, okay. He said, what do you think we ought to build there? I said, are we going to build something? And he said, well, that's why we bought it. And I said, we have a budding outpatient surgery practice, and we have enough volume for about 1 to 1.5 ORs to be kept busy. Well, what do you think we ought to build? I said, I think we ought to build probably at least 2 to 3. Well, we built 3. And I went out to Phoenix, Arizona, which was the first outpatient surgery unit that had been built, and they had a lot of experience in managing it. And I found that the biggest challenge to the outpatient surgery facility was not the OR and not the recovery room, but it was parking.
Of course, it's always parking.
Exactly. So I said to Bill Schubert, did you buy enough property for parking? What do you mean? And I said, that's the one thing that I've heard consistently about the outpatient, and that is that you'll have 1 or 2 cars per patient, and you have patients before and patients after and patients hanging on. We need a ton of parking. Well, they had obviously not thought about it, but they had bought enough property. So they covered more of the property with blacktop, and we had a unit. The unit began with 3 operating rooms, a recovery room, induction rooms at each of the operating rooms, and a place for people to stay, which wasn't the recovery room, wasn't needed, but they needed to stay there for 4 to 6 hours. And so that was the first unit that we had. It was one of the first pediatric units in the country. And we had lots of visitors to see what our mistakes were
Well, you know.
and what we had done right. And it worked. It really did. And we developed mechanisms for admission, mechanisms for supervision in the same-day surgery area, and mechanisms for supervision in the post-recovery room area. And as I say, it worked and it became very popular. And we went from 1 operating room to 3 operating rooms pretty quickly. And the surgeons loved it.
And then let's go back to what Paul brought up about the induction rooms or parents. Again,
Well,
any of you could comment.
It was not usual for parents to come into an area while their children were going to sleep. And while they never said anything to me about it, because it was just the way things were done at that time, I had a couple of parents come into the room when either their kids were handicapped or not intellectually very adept. And the parents loved it and the kids loved it. And I thought, why not? So I began asking parents if they wanted to come into the induction room. And universally they said, absolutely. And it was a very positive affair. And the parents were responsible for the kids being much calmer. They reduced the amount of pre-medicant that was used, and the kids were quieter and less fearful, and the parents were less fearful. They saw what was going on. They saw that there was no magic, that there was no abuse, that the kids were reasonably calm, and they were certainly happy to have them. And it was a success, and it was carried on in other places, and now it's general practice
I was
later.
going to say, this is pretty much routine
Yes.
now, inpatient as well as
Yes.
as outpatient. What'd you say? Yeah. Oh, all right. Good. So we're talking about the move to outpatient, but then anesthesiology has gone off in a lot of different directions. Critical care medicine is one thing that you've kind of gotten into. Again, I remember back as a resident, I mean, you guys were critical care medicine. You staffed the ICU because there was no such thing as an ICU. Doc, do you want to talk about how that developed? Or
Children's Hospital had its own roving ICU in the name of George Benzing.
yes.
And George was a pediatrician, a very bright guy, and a lovely person. And George would take care of the cardiac surgical patients postoperatively. And they had their own private nurse. And I said to him, don't you think we ought to have an ICU? And of course his response was, why? And it was pretty obvious to me, but it wasn't to George. So I said, you don't have to work there if you don't want, but I'm going to go and see if I can't get them to designate a space as the ICU. So I went to see Dr. Schubert, and he was very enthusiastic. And the person who was less enthusiastic was a man, I know you may not remember him, by the name of Bob Southwick.
I know the name.
Bob Southwick was the hospital administrator. And he didn't like to have an area which required 3 times as many nurses and twice as much space per patient, and was special in every way.
That's what the I in ICU stands for, right?
Yes, exactly. But we went ahead and did it. And George came through and helped staff it, and did so very nicely. And I staffed it, and it took off, and it was certainly accepted full force by the pediatricians, and they liked it because this was a specific place that they could find and they could put patients who could not be adequately taken care of in other circumstances. And they had been inadequately taken care of in the other circumstances because it just was not a way you took care of patients. And people weren't accustomed to it. The nurses didn't like it. They were uncomfortable with it. And although I don't know any specific case of a patient suffering from not being in the ICU, I have a hunch there were cases. And the ICU became an immediate hit with the house staff, the attending staff, and the people who worked there. And it's obviously now a huge success.
Yeah, I think the thing about ICU medicine was, depending on where you trained, it either fell under pediatrics or anesthesiology. And over the course of time, obviously, the ICU here made that transition from anesthesiology to the Department of Pediatrics. But that the number of programs where it's actually under anesthesiology are relatively few. I think there's Philadelphia and Boston, and I don't know of any other one I can think of off the top of my head, because when I did peds, spent a year at DC Children's, and there it was run by the Department of Pediatrics. And so,
You had started to talk about other fields of anesthesia, cardiac. I know that's one of your specialties. You want to talk about some of that? Yeah.
So the whole, as far as the move to outpatient surgery, I mean, we're not quite the outpatient cardiac surgery yet, but one of the big transitions that happened about the same time was we used to see cardiac patients come in the day before surgery, right, and overnight, and then they'd have their surgery the next morning. Well, it got more and more common for them to actually come in the day of. And so for us, that meant really very carefully rethinking, our intake process, the evaluation process, and also the directions we gave the parents the night before. If you have a child with tetralogy, you don't want them NPO from midnight, because a dehydrated tet is not what you want for your start of the day. So we had to rethink all of that, and very carefully, about how we laid out the instructions and everything. And I think not only did that impact cardiac, but other areas as well, in terms of how we actually developed our intake and screening processes to, where we had the entire, go see them the day before and whatever, and lots of time, to now they're here the day of, and from that evolved a consult clinic. So where patients would come in maybe a week or two ahead, and then they would be evaluated to see if there were additional testing and so on they needed. And that was one of the, again, all derivative of this move to, same-day surgical procedures.
And the neonatal surgery, that's another field, isn't it, that's relatively new? Is that one of your...
So, yeah, and a lot of that, again, as Paul suggested, was driven by changes in technology. As we got better ventilators, we had better endotracheal tubes, even better laryngoscopes, just, device, and also techniques for doing regional blocks in small babies. All of that's made a difference. And even now, the anesthetic agents we have available to us have a much better safety profile than our old standby halothane.
I suppose that's changed a lot over the years.
Yes,
too.
it has.
Yeah,
it has.
What do you use now?
So, I mean, the big one for the volatile agent is sevoflurane, and whereas everybody used to take, Paul's brought this up before, malignant hyperthermia was something, something everybody feared, and one of the provocative tests for it for in vitro was actually used halothane as one of the test agents, right? So now that that's gone, and with sevoflurane, people go their entire careers without ever seeing a case. So that's one thing that's changed. As far as its cardiovascular safety profile and everything, it's vastly better than halothane. And also now the other thing that's moved over from the adult side is intravenous anesthesia. So there are a lot of procedures now for reasons where we're actually trying to monitor physiologic signals during the surgical procedure, like spine, certain neurosurgical procedures. We'll actually use total intravenous anesthesia, and their agents now, the rapid-acting remifentanil and some of these others, have really moved that forward and enabled us to do things that would have been probably impossible to do if we were still in the halothane era.
You don't have respiratory
The physiologic
depression.
parameters are, yeah.
There were events that we would see. I mean, very, very commonly, halothane would result in pulseless electrical activity, or PEA, where
Doesn't sound
you would
very
have to
good.
do you would
Yeah.
have to do CPR for a brief period of time, and that literally was a weekly event, weekly.
Really?
And when we
Really? Wow.
switched over from
Was that just a pediatric thing, or this
it was
was
a pediatric thing, because we would frequently be doing things like, let's say, airway surgery, where you needed a fairly deep anesthetic depth fairly quickly, and it was not an uncommon event in that setting.
Wow.
And then we moved away from that particular drug, and not to say we never see it, but we hardly ever see it. I mean, it was as dramatic as when surfactant came out, and we went from
Really?
putting
Really?
chest tubes in every night
uh-huh.
to putting a chest tube in once a year.
Wow.
It was that dramatic a change.
You have to go to chest tube training classes because you never do
Right,
it
or
when
find
you-
someone who trained,
or-
in the 1980s,
and
because they
so-
knew how to put a lot of them in.
Fascinating.
I'd like to go back to
Yeah, yeah.
equipment
Yeah, sure.
to say that one piece of equipment that came to being and use in 1984 has made the biggest change in anesthesia as well as other fields, and that's the pulse oximeter. There was no pulse oximeter and no pulse oximetry before that, and you had no real way of figuring out, A, what the volume of the pulse was, what the saturation was, et cetera. And it absolutely transformed the practice of anesthesia from a real guessing game to a bit more precision and accuracy. And I had the pleasure of being part of the transition, and it was real magic to those of us who had it. And you could sit there and watch the pulse oximeter and say, gosh, that's wonderful. I mean, it was so,
Instead of waiting till their hands turn
Exactly.
blue, or, I mean,
and the next thing that went was your hands.
yeah, right. Wow.
I'm curious how the department is structured now. You've got a big department, a very, very busy surgical program. Do all the anesthesiologists have an area of specialty? So you would always do the bariatric cases and you would always do the cardiac cases? Does everyone do a little bit of everything?
There was a time when it was exactly like that.
Everybody
work?
did everything, yeah.
Well,
Yeah.
so the as the work has become increasingly specialized, people have developed academic interests and personal interests that sometimes have had a big impact on their career. I think it's fair to say that when we joined the early department, there was an expectation that everyone pretty much did everything. And I remember when I joined the department in the early 90s, I, like every other fellow, had done cardiac anesthesia and joined the cardiac group and was doing cases there as well. But since then, things have become much, much more specialized, to the point now where there are people who do chronic pain, people who do acute pain, people who are on the fetal anesthesia service, the cardiac anesthesia service, the transplant anesthesia service, to say nothing of someone who may have a particular interest in a particular kind of a procedure, like many years ago I had an interest in bariatric surgery. So many of us are on some teams, but not other teams. And then in addition to that, we might have a personal interest that maybe drives some of the activities that we have in the operating room.
And as you become more specialized, does that require more collaboration with the surgeons? Or, I mean, one thing, I'll backtrack a little. One thing I hear people talk about a lot when they talk about the culture at Cincinnati Children's is that there's a culture of collaboration. And you just talked about teams. So do you simply, the surgeon knows that you're an expert in this area and you come in, or are there meetings where you,
He asked for you, or what?
yeah, do you
Or you
plan
assign
these
them,
together?
yeah.
And just
So we
the
actually
mechanics of it.
Yeah.
have now a system, we call it microsystems, which, so there's a physician lead and also our nurse practitioners are involved with, right? So the purpose of that is then to actually, those become the point people for engagement with the surgeons, and in terms of, there are a number of them that'll actually do pre-briefs or whatever, so that the team knows what cases are coming ahead of time. That initiated with the cardiac service. It was the first one. So Peter Manning and actually started that back in the 90s, and then that's kind of continued since and been refined. But that part is where a lot of that index contact happens. And then we've developed some entirely new services that are unique to here. One of which you heard me mention before, intraoperative neurophysiology. There's this group of us that have actually trained in this, and now it is a real close collaboration with the surgeons, because essentially we're telling them what they just did, whether or not it's good for the patient or not, particularly for spine surgery or certain of the neurosurgical procedures. As to whether or not, when they're doing spine surgery and putting in pedicle screws, is this one, is it good? Nothing's changed, everything's fine, or we have a signal change and this is a problem now. So that, for those sorts of things, it has developed an entirely different level of collaboration.
Yeah. And then, Paul, you had mentioned pain management. Now that's another field that you've gotten into. It's become kind of controversial in the adult world, I think, with the whole addiction business. But how does this work in peds?
So one of the things that actually the acute pain service does now is, and it's on their list of key performance indicators, is to actually go and discuss alternatives to opioids for pain management. And a lot of them are very skilled at regional blocks, which is certainly a major way of avoiding opioids altogether. And then other alternative methods of pain management. So that's a big piece. And again, to the equipment, ultrasound. It used to be when you were doing regional blocks, you kind of look at the anatomy book, it's about here, you put the needle in here and you just put enough local in, you hope you get it. And now it's far more refined than that. Actually with ultrasound, you can get a very detailed picture of the structures you're looking for, and precisely you can watch your needle actually get to the target and even see the local anesthetic as you inject it, what it's doing. So that's changed things dramatically too. It's made a lot of these blocks much safer and more accessible in the pediatric population now than it would have been with the old techniques.
Yeah. So another topic we like to discuss when we interview people who've been around a long time is the training programs and the impact that our training has had on the development of the field, both here and elsewhere. So I believe anesthesia, that you have a strong training program, and can you tell us about that program? How many fellows do you have? And
we have I think an outstanding training program, and it's a very popular destination for students to come here. Certainly we have many non-anesthesiologists who come through, folks from the emergency room, from the ICU, from oral and maxillofacial surgery, and others who, as part of their training, spend time with anesthesiologists to learn about the techniques and the medications that we use. But in addition to that, we have a very close relationship with the University of Cincinnati that has a general anesthesia program, and so they will always send their residents to us for their general anesthesia training in pediatrics, which is a very important part of that general training. And then in addition to that, we have many people who come for a special additional year of pediatric anesthesia training. And these are people who have a deep academic interest in pediatric anesthesia and frequently want to work in a place like Cincinnati Children's. And so that program has grown over the years into a very successful program. We typically have approximately 11 or 12 fellows every year from around the country. And then in addition to that, we also have other folks joining us, like people who might have an interest in doing an additional year of cardiac anesthesia or an additional year of pain management. We also have folks from outside of the country who join us for 18 months for an international pediatric anesthesia program. So all told, there might be up to 15 or so fellows and maybe an additional group of other folks around as well. So this is a very, very busy destination for education within the operating room.
The general anesthesiology residency is how long?
3 years.
And then peds on top of
Correct.
that? 1 year, 2
For
years?
an additional 1
year,
year,
and then
or an additional time if
Yeah,
you're interested
yeah,
in one of the
yeah.
subspecialties.
Yeah, right. Any stellar graduates of this program that, or are they all great?
Well, going back to one of the very first fellows we had here was Tim Martin, and he's sort of my equivalent in the University of Florida in Gainesville, right? So, but it's peds there is sort of housed under the larger adult department,
Yeah,
but
yeah.
nonetheless. And then Dan Ness, who was with us, has San Diego,
Oh, Dan, sure.
right?
Yeah.
And so
Steve Kamadian is
Steve, right, in
Dallas.
Dallas, right?
Eve Overby is COSAIR.
Yeah, and we've got, we sat and thought about it a while. We'd come
Yeah,
up with a
yeah,
list of
yeah.
former fellows that are either, chairs or manage the education programs or other high positions in either freestanding children's hospitals or children's hospitals within an adult system. So,
But I would say this about our fellows, having run the fellowship program for many years, and that is that our fellows have always had really an incredible reputation for being incredibly talented clinically and incredibly pleasant people to work with. And that is exactly the sweet spot that you want to find yourself when you're looking for a job and when you're hiring people. And I can't tell you how many times people have called me saying, "We love the person that we hired from you last year. Do you have any more like him or her?"
That's fabulous.
Yeah, that's wonderful. Yeah, that's great. That's great. Well, should we get we were starting to talk about simulation since we're talking about training. The simulation training
So-
program, tell us.
So
yeah,
imagine you walk into a room and there's a mannequin that can open and close its eyes and has heart tones and is breathing and can even speak to you. And that mannequin is hooked up to a monitor so you can see its vital signs and interact with it as if it were a real person. And then into that environment, you can introduce all kinds of events to practice dealing with the kinds of issues that as anesthesiologists we rarely have to deal with, but when we have to deal with them, we need to deal with them in an organized and highly competent way.
So this is way beyond just basic CPR. This is
This is the
complicated
management of complex perioperative problems, and it's not dissimilar to when a pilot who works for a major airline goes into a flight simulator and they have to go through drills associated with specific kinds of serious abnormalities that again rarely happen, but they need to be highly proficient at managing them.
And how long is this? I mean, how did this develop? This sounds pretty high tech, or has this been around for a long time?
The mannequins have been around for about 15 years at this point.
Okay.
They certainly get better and better, but the other thing that's been really very fortunate for us is there was a time when the infrastructure associated with those mannequins was such that you really had to go to a specialized place because there was so much technology that went with them, and now they've become portable enough that we can bring them to to us and set them up in operating rooms or in the emergency room or in other locations where you might find them in real life, so that we can not only look at things like how do people perform when these events come up, but you can also look at things like systems and how do those systems respond to these kinds of events. So, you know, when the code alarm goes off in the emergency room, who shows up and how long does it take them to show up and how do they communicate with each other once they do show up, rather than having that take place in an artificial environment in some lab somewhere.
It's more and more realistic.
Yeah.
Right.
Yeah.
Absolutely.
Right. And to that point too, the best part is you actually drill with the people that you would be doing the actual event with. So, and things like, okay, who's leading the code? Who's the leader? You know, who is on meds? Who, you know, are these roles assigned quickly? Those sorts of things. To Paul's point, you can actually watch that, and then that's the focus. The most important thing now we've learned from the simulation is actually not the content of the sim so much as the debriefing. So how did people do, what did people do right? And really, that's the first thing to say, this and this went really well, and then get into the things where, okay, if you had to do this over again on this step, how would you do? And so through that debriefing process, you actually see the improvement. And again, training with the people that you would actually be running the actual event with makes a big difference as well too, because it just gets those channels built in, so you're developing a solid team. And knowing too that team needs to be flexible is the reason why you keep coming back to the same location, so there'll be different people involved each time.
And how often do you do this? And who does this?
So we actually have collaboration with the ICU. So there are a couple folks from the ICU, from the Sim Center, and then Mike Sikora from our department is one of the leads on this, as he's went out and got his master's in medical education and everything, and then it's really become passionate about driving the SIM program. So we try and do at least one a month in either the PACU or the OR. And then the plan is, as time moves on, to actually move these to a little higher frequency. We just obtained a better mannequin, one that actually interacts with the monitors we use in the OR every day. So now we don't have to have a separate computer screen up there with the vital signs for the mannequin. It shows up on all our instrumentation now. So.
That's fascinating. Fascinating.
We did want to ask a question about research. Just, is there a formal research program who's involved in research in anesthesiology, and what, if anything, would you say are, what are things that are coming?
So actually, we're fortunate. The research program really took off, or began, I guess, its roots in 2002. When Dean Kurth came in and established at that time what was called the Institute for Pediatric Anesthesia, which was really the research arm of the department. And the initial focus there was on developing a very strong program in quality improvement and basic science around neuro, and then also some provision for clinical trials. So there have been instances where pharmaceutical companies would come and needing pediatric patients, so they would work through that arm. Inavarghese really became big on getting the quality improvement going, right? And actually established a fellowship, an advanced fellowship for that. And then the neuro started basically with me doing hypoxic ischemic injury in a mouse model. People had been doing it in rats, but we decided to take it down to mice because at that time there were no really good genetic manipulations available for rats or anything larger than a mouse. So it meant it was logical to start there. And then as that moved on, one of our first big recruits was Steve Danzer. Steve just recently received an endowed chair for pediatric research, and we also have a second endowed chair, Mike Jankowski, who sits in the Ted Stryker
Wow.
Nice.
chair.
excellent,
So
excellent, yeah.
yes, so that was really huge, and of course Steve was instrumental in getting Mike here. So Steve's focus is on epilepsy and genetic defects that can lead to that, and Mike is really all about how peripheral nervous system actually affects pain perception and so on. And they're both well funded from NIH, and so that's been a big part. Now, on the clinical side, one of our faculty, Vidya Chimbattaran, just recently received an R01 for her work on genetic and other determinants for chronic postoperative pain syndrome in children, so, which is huge. There are very few R01 funded practicing pediatric anesthesiologists in the country. I think you can count them on one hand with a couple fingers missing. So that's big. And so research has transitioned really from more of a individual mom and pop thing to, and there still is some of that, and we have a mechanism to foster that, but to a more organized and where we actually have full-time PhDs doing hardcore basic science, and also they are willing to provide a platform for any faculty member who wants to become involved. There are ways, that little side streams that they can generate that people can get involved with if they're interested in basic science.
Great. All right.
Glad I asked.
Good, yes,
know about
I'm
any
glad
of
you
that,
did.
yeah.
I'm glad you did, yeah. So we're starting to wind down. Is there anything major, I'm sure there are major things we haven't covered, but anything in particular that you would hope to talk about while you're here?
I want to say something about Ted Stryker.
Okay.
I hope you don't mind, Ted, if I just embarrass
what
you
he
just a little bit. But the reason that I am here is because of Ted Stryker. I will never forget when I came to interview and he looked me in the eye. And what I mean by that is that there are a lot of times where you're interviewing with someone and they look like they're looking at you, but they're really not looking at you. They're kind of looking over your shoulder to like the next opportunity behind you. And that was not Ted. Ted looked me directly in the eye, and he listened to me as he listened to all of his staff. And to me, the sort of the legacy that Ted left on the department, the stamp that he left on the department, is that personal relationship and that deep commitment to not only the department as a group, but to us as individual physicians. And I still feel that that connection to that kind of fundamental value, and it will always be something incredibly important to me.
Excellent.
So I will second that. Seriously, no, when we moved out here, my wife is a lifelong New Englander prior to coming to Cincinnati, and we had 3 kids under 4. When the first week I was here, the youngest one was 6 weeks. So moving to a whole new location, not knowing anybody, having no family, nearest family is in New Jersey, was a bit daunting. And Ted really went out of his way to make us feel welcome, and also help plug us in with people. I remember, and okay, there's things to do and for the kids and so on, and that was huge. My wife said, before we actually really got planted, said, yeah, we'll be 3-5 years and then we'll go back to New England, right? Well, it was 35 plus,
Plus.
35 plus, right? Because we're coming up on 35 years in May, and it's, you know, largely from Ted. And I have to say that a lot of the things I've learned from him, I've tried, to Paul's point about trying to maintain personal connections and stuff, is something I'm not perfect at by any stretch of the imagination, but I really try and work on and think about, you know, practice every day as that was something very, very important. So, and I think it will continue to be important for anybody that wants to lead this department to really focus on those personal connections to not only the faculty, but everyone in the department as much as possible. It's over 200 people now. It's a little bit bigger than it was, but that said, nonetheless, I think that's an important value that he left and needs to be passed on.
Yeah, excellent. All right.
Quite a legacy.
Yeah, I'd say. Good way to.
Yeah.
It's a good way to wind things up, unless you want to have the final word.
I don't.
Yeah. All right, you heard it here.
Thank you so
Thank
much.
you all for coming. This has
thank
been
you.
great.
Thanks
Thank
for
you,
having
guys.
us.
And,